The first speaker is Dr. Joseph Flynn, who will be discussing the 2017 AAP Guidelines for Child Hypertension Highlights, which was just published this month in Pediatrics. Dr. Flynn is Professor of Pediatrics at University of Washington School of Medicine, Chief of the Division of Nephrology at Seattle Children's Hospital, and holds the Robert O. Hickman Endowed Chair in Pediatric Nephrology. He has served on the working group of the National High Blood Pressure Education Program, is past president of the American Society of Pediatric Nephrology, and co-chaired the Academy's committee charged with developing new guidelines for child hypertension, which will be used by all of you in the management of your patients with hypertension. Please join me in welcoming Dr. Flynn.
Well, thank you for that introduction, Dr. Ghali Otto. It's my pleasure to be here and present to you the current clinical practice guidelines for childhood hypertension. I am speaking again this afternoon, and if you have questions about the talk, then please try to find me right before my afternoon session. So these are my disclosures, and of course I was one of the co-chairs of the committee. So why a new pediatric hypertension guideline? Well, several reasons really. First of which, the last guideline was in 2004, so quite a long time ago. And then we know that over the past several years, there's actually been an increase in the prevalence of hypertension in children, so that now around 3.5% of all children really qualifies having a diagnosis of hypertension, making hypertension one of the more common chronic conditions in children. Another 10 or 11% of children will have elevated blood pressure, and much of this is being driven by the increase in childhood obesity, which I know you're all very familiar with from your practices every day. We know that high blood pressure in children increases the risk for adult cardiovascular disease, and that you can even see evidence of vascular aging in young people who have had elevated blood pressure. So clearly there is a rationale for focusing on the area of childhood hypertension. So we were charged with developing an updated evidence-based clinical practice guideline to provide recommendations on the diagnosis, evaluation, and management of childhood hypertension. The guideline is primarily aimed at clinicians who see patients in the office. There's one small section on acute severe hypertension, but really the guideline is focused on the outpatient setting. There are some major changes in the new guideline compared to the 2004 fourth report, beginning with the fact that we followed an evidence-based methodology for this guideline as recommended by the Institute of Medicine. We have revised some of the definitions of the blood pressure categories, and they really will align very nicely with the forthcoming adult hypertension guideline that is being put together by the American Heart Association and American College of Cardiology. As you will see, there are new normative blood pressure tables and a simplified screening table, which we hope will be very useful. We now emphasize the use of 24-hour ambulatory blood pressure monitoring to confirm the diagnosis of hypertension. There are revised recommendations for performance of echoes, and then new lower treatment goals for both primary hypertension and hypertension and chronic kidney disease. So we followed an evidence-based methodology for development of the guideline. And as I mentioned previously, this is really what has been recommended by the Institute of Medicine for any clinical practice guideline. Our epidemiologists put together several PICO-T questions that were used to conduct a comprehensive literature search. There were 15,000 papers that came up, published since 2004. We didn't read every word of all of them, for sure, but they all got looked at to see whether they would be relevant. We generated key action statements, and there are 30 key action statements in the guideline that are derived from the evidence review, and we used the well-known AAP grading matrix, which is pictured there, to grade the level of evidence and the strength of the recommendations. So what about the definition of hypertension? Well, we know that pediatric hypertension is different than hypertension in adults. Lucky for us, children don't have heart attacks and strokes from high blood pressure, so we can't use an outcome-based definition for childhood hypertension. Therefore, childhood hypertension is based upon the distribution of blood pressures in healthy children. And this has been the approach really for the past 40 years in all pediatric hypertension guidelines. Our subcommittee reviewed the evidence and concluded that we needed to follow the same approach because we don't yet have better outcome evidence in pediatrics. Now, we did make a few changes, though, compared to the fourth report. So now, blood pressure greater than the 90th percentile is termed elevated blood pressure, which we hope will be a better term than the prior term of prehypertension. We have simplified the cut points for stage 1 and stage 2 hypertension, and then because the 90th percentile for adolescents really comes in at 120/80, which is the adult cut point for elevated blood pressure, we decided that the cut points for adolescents 13 years of age and older should be exactly the same as the cut points in the new adult guideline. So this is the table 3 from the clinical practice guideline, and I'm not going to lead you through this in detail. You can download the document and look at this, but you'll see that we still have percentile-based definitions for younger children, and then just straight specific value cut points for older children. Now, the blood pressure tables in the fourth report were criticized almost as soon as we published them because the database of children that was used to derive those values contained a significant proportion of children with overweight and obesity. We know that overweight and obesity can lead to elevated blood pressure, so those tables were potentially biased upward in terms of the blood pressure values. So for this guideline, the American Academy of Pediatrics commissioned a reanalysis of the pediatric blood pressure database to only include blood pressure values obtained in children with normal BMI. And so, therefore, the new normal values actually are 2 to 4 millimeters of mercury lower than the old values. We also changed the tables a bit to include actual heights and to include the actual staging system. Now I'll show you a slice of the table. I'll blow up a little bit of it for you. And so as you see, it's still percentile or measured height, but we have included the actual heights, so you don't actually need to go to the growth curve to figure out the child's height percentile. And then we have included cut points for the 90th, 95th, and 95th plus 12, which is the new stage 2 hypertension, as those values are in the new tables. We also developed a simplified blood pressure table for screening purposes. We know that pediatric hypertension is under-recognized and under-diagnosed. In fact, my co-chair, Dr. David Kalber, has published some seminal studies that showed that only around a quarter of children with hypertension are actually diagnosed with hypertension by their providers. And one of the reasons for that is that the tables, let's face it, they're complicated. So we created a simplified table which is to be used just for screening purposes. It's based on the 90th percentile for children at the 5th percentile of height for each age. And blowing that up a little bit so you can see it better, for each age there's one blood pressure value for boys and for girls. And what we envision is that this table could be posted in the office vital signs station so that your medical assistant could figure out, well, this is a child whose blood pressure might be high, and they could alert you to that so that you could then go back and consult the full table to see whether or not that child truly has elevated blood pressure. Now, the key action statements, as I mentioned, there are 30 of them, are all structured like this in the main guideline. I'm only going to show you this box once to show you how they're put together. So the top of the box has the actual action statement itself, and the bottom of the box has a summary of the evidence quality and the strength of the recommendation, and even the references for if you want to go back to the primary literature and see how these statements were derived. So key action statement number, and from now on I'm only going to show you the text of the key action statement so you're not distracted by these boxes. So key action statement number 1 is how often should you measure the child's blood pressure? And this is one of the changes. We are now recommending that blood pressure should be measured annually at the child's regular well-child visit, not at every healthcare encounter as was recommended in the 4th report. However, key action statement number 2 does go on to say that there are some children who we feel should have their blood pressure measured at every visit. These are children with obesity, with kidney disease, with coarctation of the aorta, or other conditions that may increase their blood pressure. So every opportunity should be taken to screen these children for elevated blood pressure. And you know, as well as I do, that children's blood pressure is quite labile, and you cannot make the diagnosis of hypertension on one blood pressure value. But there are many reasons why a specific child's blood pressure might be high that day. Maybe they just had a test, or you're about to give them 3 immunizations and they're worried about the needle stick. So therefore, we continue to recommend that they should have multiple measurements made over a period of time before a diagnosis of hypertension is made. So key action statement number 3 is that a trained healthcare professional should make a diagnosis of hypertension if a child or adolescent has auscultatory confirmed blood pressure readings at or above the 95th percentile, or at or above 130/80 for a teenager at 3 different visits. Now, there's also in the document a discussion of what to do at each visit and by the blood pressure level. I can't take you through this in detail in this talk, which is pretty short, but I'll blow this up a little bit, and just to show you that for each blood pressure level, we outline the different steps that are appropriate for a child whose blood pressure is at that level. So, for a normal child whose blood pressure is normal, they get their blood pressure measured at their next annual checkup. In contrast to that, child whose blood pressure is at stage 1 hypertension level needs to be brought back for repeat measurements, needs to then undergo ambulatory blood pressure monitoring if it's persistently high, then have a diagnostic workup, then potentially initiate treatment, and so forth. Now, what about the method of blood pressure measurement? Many offices utilize oscillometric devices for measuring blood pressure. You push a button, it gives you a number, so it's pretty easy to get a number that way. But the issue with that, well, there's 2 issues. One is that number isn't really a blood pressure, and I can go into detail more about that later. And secondly, all of the normative values for children are based upon auscultatory blood pressure measurement. So we have to be able to compare apples to apples when we're diagnosing hypertension. So for oscillometric devices, what we recommend is that they're useful for screening. You need to use the device that is validated in the pediatric age group, and then if it's elevated using that device, then obtain confirmatory readings by auscultation. Now, we put a lot of emphasis in the report on ambulatory blood pressure monitoring. For those of you who are unaware of what that is, it's a procedure in which the patient wears a blood pressure cuff for 24 hours, takes the blood pressure a whole bunch of times over that period. We usually get between 50 and 60 readings over 24 hours. It allows us to evaluate the blood pressure in many different settings, particularly outside of the office. It allows us to also look at circadian variation of blood pressure, which can be abnormal in certain conditions. It has really been used more and more in pediatrics. The fourth report mentioned it as being useful, but did not endorse its routine use. But now there is much more data available on the utility of ABPM in a variety of clinical settings, and also showing that it's cost effective. So because of that, we are now joining many other consensus organizations in recommending that ABPM should be used in the child or adolescent with elevated office blood pressure to confirm the diagnosis of hypertension. There are other uses of ABPM as well. Children who have high-risk conditions like chronic kidney disease or aortic coarctation or diabetes would benefit from ABPM, and ABPM is the preferred method of making the diagnosis of white coat hypertension, and criteria for that diagnosis are actually given in that key action statement. Now, echocardiography has been used over the years to look for left ventricular hypertrophy, which is one of the most prominent forms of hypertensive target organ damage in children. Can affect up to 30 to 40% of children with primary hypertension. We know that it increases cardiovascular risk. The fourth report recommended echocardiography at the time of diagnosis of hypertension. However, we are recommending that echocardiography can be deferred until such time as you are contemplating starting the child on antihypertensive medications, and that's the major point of Key Action Statement 15. There are other points on echocardiography that are different. There are new definitions of LVH, and some other recommendations about when to repeat it. The basic message is that we want people to focus on the blood pressure value and not on the result of the diagnostic test when they're approaching treatment in children with hypertension. Now, what are the overall treatment goals? So there's new data that show that even children can benefit from a lower blood pressure. So we're recommending that blood pressure be lowered to below the 90th percentile or less than 130/80 in an adolescent. That treatment should begin with lifestyle modification. So the next key action statement says that children with elevated blood pressure or hypertension should be counseled regarding the DASH diet and increased physical activity. There are children who require pharmacologic treatment. Those are children who have failed lifestyle changes, who have symptoms of hypertension, or have stage 2 hypertension without a modifiable risk factor. First-line agents could include an ACE inhibitor, angiotensin receptor blocker, calcium channel blocker, or thiazide diuretic, except in children with chronic kidney disease or diabetes, they should be treated with an ACE inhibitor or angiotensin receptor blocker. And all of that is summarized in Key Action Statement 21, which basically repeats what I just told you. Now, calling out specifically children with chronic kidney disease, these children should be evaluated for hypertension at every encounter. If they are hypertensive, they should be treated to a goal of less than the 50th percentile of mean arterial pressure on ambulatory blood pressure monitoring. not an office blood pressure goal, but an ABPM goal. And they should also undergo frequent ABPM to be screened for masked hypertension. Children with diabetes should be evaluated at every encounter for elevated blood pressure and treated if their blood pressure is at or above the 95th percentile or at or above 130/80. Now, there are many things we don't have answers for. You can see them listed here. We don't know what the actual long-term consequences are of high blood pressure in children. We don't know what is the best medication to use. So definitely many more studies need to be done to develop the evidence to fill in these gaps so that when we update these guidelines in however many years, if I'm still around, that we'll have the ability to answer the questions that we don't answer, we cannot answer today. So just repeating the major points, they're listed here. Changes in the hypertension definition, revised tables with the screening table, use of ambulatory blood pressure monitoring, and lower treatment goals. I'd like to thank everyone else on the subcommittee for all their hard work. I'd like to thank you for your attention.